emphysema, bullous emphysematosis, which is the most common cause actually, okay? So, traumatic pneumothorax, if you suffer a motor vehicle accident or you go into a fight and you have chest fractures and that punctures the lung, then you have traumatic pneumothorax. And remember, tension pneumothorax is no more than, is basically a one-way valve that creates high pressure, high barometric pressures inside the thoracic cage that displaces the diaphragm to the contrary side, right? So therefore, it impedes the preload and afterload. I'm sorry, impedes the preload and cardiac output. All right? So that's not the best image for pneumothorax. So let me open up one, for example, from the internet. So where's the pneumothorax? Right there.
Right lower lobe.
Really? So you have bilateral pneumothorax? That's it? No, because this is not pneumothorax. It's a breast. What about what is pointing to it?
The black line in the top, to the side.
What about here?
It's all black. Oh, and the top.
Compare pulmonary tissue to none. Do you see, first of all, you have a line. The lung is right there. But remember that I told you when we were going through the anatomy that you need to have vascularity all the way. So you see that spider web, right? And here's dark. Okay? Air, black. All right? Is it creating a tension? Is it deviating the mediastinum to the contrary side? Of course, yes. Look right there. It's completely to the side. Maybe the patient is not hemodynamically stable, but the mediastinum has been shipped. You don't? Well, first of all, your right and left is here, but look at the aortic hole. It's deviated completely to the side. It's not midline. You have the vertebrae right here, and you have the upper portion of the mediastinum to the side. Most likely, it's not producing a hemodynamic change yet, but this is a tension loop. Now, if you compare that one with this one, look at the deviation to the contrary. So if the mediastinum is deviated to this side, this should be the area of pneumothorax, right? Give me 1 second. Hello. Okay, so where do you see the pneumothorax? Look along, right there. And it's creating a shift completely. Look, this is midline, and this is the heart. Mediastinum and heart. This patient is severely in obstructive shock, for sure. Going through the PowerPoint again, we have for the pneumothorax, we went through tension. Remember, tension pneumothorax is an emergency. Okay? I understand that we do prepare the patient with chest tubes, right? Placement of a chest tube thoracotomy is the name of it. But do we have time to prepare that if the patient has tension pneumothorax? No, right? By guideline, the answer should be a large bore needle, right? In the second intercostal space, right? In clinical practice, if you do that, it doesn't work. Yeah. We do what's called finger maneuver, meaning that, and we have done it twice already, and I was really impressed when I saw that because to me, I mean, I've never been with the tension pneumo, I mean, I've been impressed with the tension pneumo, but not with the hemodynamic changes to the point that we don't have the time to prepare a chest tube. But I saw one time a large bore needle and then placement of a chest tube, but 2 times in the ICU at Kendall Regional, we have seen the large bore needle being placed and doesn't work. So therefore, they basically go open, dissect, and place your fingers. And you feel the gush of air coming through your fingers. In preparation for the chest tube. So you basically do the first portion, which is no more than cutting, dissecting, and then you place your fingers. Can't wait for the chest tube. When the chest tube is prepared, then you go right there and put the chest tube. Finger. Because it's your finger. It's not described anywhere. You're not gonna find it in the literature. You're not gonna find it. Métele el dedo. Okay? So then, so one of the questions that you might get on board examination, where do you place the needle? Remember? Second intercostal space, right? Make clavicular line. So on the chest tube, 4th to 5th intercostal space, anterior axillary line. And pleural effusions, remember that we said that for first fluid is dense, right? As you can see it white. Most of the time the fluid goes down to gravity, so it's going to occupy the costophrenic and cardiophrenic angle, unless it's loculated. Second of all, most of the time the fluid has level, so you can see the actual level of the fluid, right? And of course, depending on the amount of fluid, you do thoracentesis or not, right? Why? Because if you have a small pleural effusion, you're not going to do thoracentesis. You need more than 500 mL of fluid to do thoracentesis, even though we have seen ultrasound and taken 50 mL. No reason, right? 50. I have seen 50 coming out. No, it's not. Because there's a high risk of creating pneumothorax and also infection, penetrating infection. Unless they do it for therapeutic purpose, for diagnostic purposes, that is justified. But for therapeutic purposes, just to improve the patient's shortness of breath, if you have mild effusion, it's not justified, okay? Now, remember that CSF, you went through the classification, right? Transudate versus exudate, and based on that and the clinical history of the patient, you have an idea what is the etiology, okay? And this is what I told you, that you need at least 200 mL of fluid to be able to be seen over the costophrenic angle, even though he has 250 to 300. And again, as I told you, when in doubt, you don't know if you have effusion or not, based on clinical patients' symptoms, do a lateral decubitus. You only need 50 mL for that. Okay? So, the majority of the time, having asymmetric effusion, meaning one side effusion versus both bilateral. If you have bilateral pleural effusions will make you think about more systemic conditions such as cardiomyopathies or cirrhosis of the liver, right? Cancer, etc., right? Or hypoproteinemia for any other catabolic state. If you have a unilateral effusion, most of the time, you might think most likely this is related to a tumor located at this hemidiaphragm, or most likely is related to a pneumonia concentrated at that level. Do you understand? Because again, cardiovascular conditions are systemic conditions, so you expect to have bilateral symmetric either congestive heart failure or pleural effusions, right? Most of the time it's not unilateral. So for example, pneumonias or any type of inflammatory conditions such as PE or cancers versus having CSF, for example, or any type of catabolic state or cirrhosis of the liver that decreases on cardiac pressure. So this is what I just told you, that remember, you have the heart, you could have pleural effusion as a mass, meaning it's loculated. That's the reason why it doesn't occupy the angles. But most of the time what you're able to see is the fluid coming down by gravity and occupying the cardiophrenic angle and costophrenic angle. And remember, most of the time when it's large enough, produces a level. And that's how you can determine if you have an asymmetric pulmonary edema versus, for example, a pleural effusion. Now, when you have pleural effusion, let me tell you, there is such a thing called asymmetric congestive heart failure, okay? You expect 99% patients having congestive heart failure occupying both lungs. Why? Because again, it's a systemic condition. But sometimes, rare, but I have seen it, I have seen it, you will see it, that there is something, patient coming in with only one lung congestive changes or one lung effusion only. And it's not related to pneumonia, it's not related to cancer, and it's not related to pancreatitis or any type of inflammatory condition such as PE. And many times it's related to congestive heart failure. And many times it's related to left-sided heart failure. And you're like, I have right pleural effusion and left-sided heart failure, impossible. But it is. Why? Because if you remember, I don't have anything to write with. Did you bring it?
Yeah, right.
Inside or outside?
Yeah. No, it should be inside here.
Oh my gosh, you have plenty. This is the left side of the heart and the left side of the lung. So imagine that this is your chest, right? Divided in there, right? So if you have left-sided heart failure, meaning that you either have a left-sided valvulopathy or decreased ejection fraction, imagine aortic stenosis or mitral stenosis, what's gonna happen with the pressure? Increases and regurgitates back to where? Pulmonary veins, right? Pulmonary veins. So it's gonna engorge the pulmonary vasculature, but then, who's here?
Right ventricle.
Who's here? The pulmonary artery, right? So it's gonna go where?
Right, oh.
To the right side. So sometimes when you have a patient with right pleural effusion, and I understand that you're gonna get a transudate anyways when you analyze that fluid, but imagine that it's a mild effusion and you never get the chance to do a thoracentesis to analyze that fluid. And the patient has no signs and symptoms of pneumonia. The patient never came in with lipase elevated, so it's not pancreatitis. You do a CTA, and yes, the effusion is there, but there's no pulmonary embolism, there's no pneumonia, so there's no causes of unilateral effusion. And the only thing that you find is that the echocardiogram, patient has either left-sided valvulopathies or an ejection fraction decreased. That's the reason why it always goes to the right side and never to the left. So asymmetric pulmonary edema could be related to heart conditions, mostly left-sided heart failure. But most of the time, what you see in clinical practice in 99% of the patients is bilateral symmetric pulmonary edema from CHF, either diastolic or systolic. What do you see in CHF? Well, first of all, let me show you a real one because that X-ray is really bad. First of all, you have an upward redistribution of the vasculature. Besides, you have what's called curvy V lines. You see it? That is pathognomonic or CHF. COPD, you know what COPD is. It's basically no more than a component of chronic bronchitis and emphysema, chronic bronchitis with a chronic cough productive for the past 3 months consecutive 3 years. And the patient either has an alpha-1 antitrypsin deficiency or cigarette smoker or pneumoconiosis, meaning that look at where the patient works. Textiles, industry, patient that works with fabrics, fiberglass, painting, any toxic fume exposure can also lead not only to pulmonary fibrosis but also to COPD. Emphysema meaning destruction of the receptor of the alveoli, right, with the same risk factors. Patients, remember that this is an obstructive pulmonary condition, that the only way you diagnose is by pulmonary function test, not by a chest x-ray or symptoms. That will be a question as well. But at least the chest x-ray will give you a guidance, right? Even though it's not diagnostic. What will you see? Since it's an obstructive pulmonary condition, and the residual volume on the PFT is the one that increases and increases and increases every year, the patient has what's called hyperinflation or autop. So therefore, the diaphragm flattens, they're in constant inspiration, prolonged expiratory phase, and that's the reason why you're able to count down more reps besides the fact that the diaphragms are flattened. Look at that x-ray. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. If we count the anterior, you have 1, 2, 3, 4. I don't even see that much. 5, 6, 7, 8, 9, 10. Well, I count 10. But if you compare a normal x-ray with an x-ray of COPD, 1, because remember, 1 is here, 2 below the clavicle, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12. This is 12. So you have an elongation of the AP diameter, and if you look at those diaphragms, right is not higher than left, they're actually equal. So that's what's called flattened diaphragm, okay? All right? So this is, I mean, it's not the best view to teach, that's why I opened it. So a cardiomegaly patient, let me show you if I'm able to open on the one x-ray. Do you see the scapulas inside the chest? I see the scapula, but they're completely outside. Do you see it or not? Yes or no?
Yes.
Okay, this is the scapula. It's completely outside. Now, let's take the biggest width, which is this one. So this is the proper VA view, and transfer that width into a heavy diaphragm. Right there. Cardiomyopathy. Why? Well, cardiomyopathy, valvulopathy, congestive heart failure, you name it. Pericardial effusion, tamponade. If the patient is hemodynamically unstable, most likely will be tamponade, right? Otherwise, patient, you have cardiomegaly, do an echo. Echo's gonna tell you everything, right? If the patient has pericardial effusion or any valvulopathy or any cardiomyopathy, etc. All right? Abdomen. So again, remember that you could do an abdominal x-ray, flat, laying down, or standing up as well, right? What do you have to look for? Basically, number one, in a normal KUB, you must have what's called psoas muscle stranding, psoas muscle lining, okay? Which are, of course, the lines were made for you when they're present in an oblique view next to the spinal column, okay? So you will be able to see the 12 ribs. This is your lumbar spine. This is not the best view, but I can open one. The kidneys, bilaterally, right? These are the psoas stripes. And you see air, right? That's the column. And here's the bladder. And you have your hip, right? And iliac crest. And again, this is the gastric bubble. Let me open a real one. Okay, so tell me you don't see it. Do you see this line?
Yes.
That's the psoas striatum. It has to be present. It's normal. If it's not present, that means that you have an inflammatory process or infectious process in your belly. That could be from an abscess to colitis to perforation to an obstruction. We don't know what it is, but that means that further studies or further investigations must be made. That patient is not normal, exactly, CT out. Do you understand? You must be able to see the psoas striatum, the lining, right there, okay? So you have the gastric bubble. This is the ascending column. You don't see the kidneys, but at least one callus there, but they must be here. I don't know if you're able to see the calluses there. Do you see it or not? That little gray thing? So this is one kidney, this is another kidney. You have the spine. This is also feces, and this is your bladder, iliac crest. Okay? So this is another view. Now we're going through the bowel obstruction, but already we discussed in GI, remember? Okay. So remember that bowel obstruction, you can have a small bowel obstruction and large bowel obstruction. You remember the number one leading cause of small bowel obstruction? Adhesions. You forgot, you should close the chapter already. And large bowel obstruction, cancer. Until proven otherwise, right? What was the pattern of small bowel obstruction? Ladder pattern. What else? The pearls, like if you're counting a rosary, remember? That. But it's also mid-level versus the large bowel obstruction is peripherally, and you see the ostrus, right? Exactly what it says there. So that's described there, and here too. That rosary thing is called valvular connivent. Valvular connivent. It's right here. Valvular connivent. It's no more than, it looks like either a rosary or a stack of coins or a ladder, like a stair going up. Okay? So that's basically in physics demonstrating it. Now, if you do lateral decubitus, for example, or even upright, look at the string of pearls, like rosary, what's called again the connivence, right? Or the stack of coins, however you want to call it. Do you see it or not? So those strings. And also remember, it's mid-level. Mid-level. In both, you're going to have air fluid level, but the air fluid level for a small bowel obstruction is a ladder pattern, and it's mid-level, mid-center. Okay? Versus, again, large bowel obstruction, you see dilation of the bowel, mostly in the, where's the large bowel running through? Peripherally, right? And you're able sometimes, when there's so much distension and inflammation, you're able to see the actual ostrus. Let me open a real one. Look, first, look at the bubbles going up, like in a stair. right? Look at the sternal pearls, okay? So the level's going up, sternal pearls, and the level's going up. So it's going through the mid-center. Look at the levels going up and the sternal pearls. So that's small bowel obstruction. Versus I know it's a back and forth, but at least this is a summary of whatever I had in 200 slides. Look at that. I mean, of course, don't tell me it's in the center, professor. It's so distended and it's so heavy that actually dropped. But this is the transverse column that dropped down. But I want you to please look at the distension first and also look at the ostrax. It's actually depicting the entire anatomy. That is large bowel obstruction. Okay? Any question? Now remember, if you have any level of suspiciousness of bowel perforation, even though you have air fluid level in the abdomen in a KUB, that's not the best view because you have the same air fluid level in bowel obstruction without perforation. Besides the fact that the clinical side effect of the patient will be severe abdominal pain and also guarding, right, and rigid abdomen, signs of peritonitis. But in addition to that, when you do a KUB because remember, chest X-rays sometimes occupy the upper abdomen, but also KUBs occupy the lower chest. You see the double diaphragm. Okay? Cervical spine. First of all, in cervical spine, you have your occiput odontoid process, right? Remember that you have C1 and C2. Remember that this is C1, which is atlas, right? And C2 is the axis. You remember that? Okay. So you have to look at the odontoid process to be able to see if there's a fracture. Sometimes it's not visible and is there, but the only way to see the odontoid process for your clinical experience and also for exams is to do an open mouth view. You have to open mouth and the x-ray goes through the mouth to be able to see the axis, the odontoid process. So, but first of all, the most important for basic entrance level is to see if the spine is aligned, okay? So you have to trace an imaginary line through the vertebral bodies, which is an anterior line. You have to also trace an imaginary line through the spinous processes, okay? And also you have to trace two more imaginary lines through the canal, the medulla canal, and the center. So basically what you have to look at is that all the lines must be symmetric. If you see any asymmetry, this is an indication of dislocation, okay? Now, for pediatric patients, the majority of the fractures or dislocation happens at the level of C1 and C2. For adults, most of the time is C4, C5. Yeah. So basically here what it says is that for pediatric patients, since I told you C1, C2, he has C1 to C4, but if you look at the website that I will send you, which is from medical school, and most of the time is most commonly C1 to C4. Basically what you have to look at this para-odontoid masses, the C1 and C2 looks like if it's completely hogging the vertebral body. It's fused, it looks fused in the x-ray, right? If you don't see that fusion, that means that there's a dislocation. And for the adult, most of the time is lower than C3, okay? Again, look at the alignment. All the spinous processes must be aligned. If you see any type of asymmetry, most likely it's a dislocation, and you will have to do a lateral view. This is what I told you. The only way to see the axis, which is the second vertebral body, is to do an open mouth view. Okay? So look at your landmark. If you remember, this is the occiput, right? The occipital area, and right here you have what's called the occipital condyles. I don't know if you remember that. Do you remember that? Yeah. Okay. So basically, when you look at the X-ray, the occipital condyles should be at this level. Okay, and between the occipital condyle and the atlas, the children, for example, shouldn't have a separation more than 7 millimeters. So the separation between the occipital condyle and the first vertebra should not be more than 7 millimeters. Do you understand? In pediatric patients. For adult patients, we look at the separation between the condyles and the C5, C6, and it shouldn't be more than 21 millimeters. But so this is what it says here. And again, if you open a patient's mouth and you pass the X-ray through the mouth, that's the only way that you can see the odontoid process of the second vertebra, which is called axis. This is the atlas, which is the first, and this is the axis with the odontoid process. There's many fractures at that level in motor vehicle accidents, and mostly in children. Again, this is mostly pediatric, but it's here in the elephant. Okay, so if we're looking for thoracic or lumbar spine, the same way, do an imaginary line passing through all the vertebral bodies and spinous processes, and also anterior and posterior, and see if there's any type of misalignment. In addition, look at the spaces between the vertebrae to see if it's also symmetric, because sometimes you have what's called compression fracture. Okay, lateral view as well. You do an imaginary line through anterior, posterior, and the spinous process to see if there's any misalignment. So, questions you have, the easiest way to distinguish between the pleural effusion and a pneumonia on a chest X-ray is that a pleural effusion, you lose the claustrophrenic angles, you lose the cardiac and diaphragm borders, air fluid level, or all of the above. All of the above. Are you sleepy? The easiest way to distinguish cardiomegaly from pleural effusion on a chest X-ray is that cardiomegaly, you lose cardiac and diaphragm borders, not at all. Both cardiac and diaphragm borders are preserved. No. Yes. Difficult to tell on PA. You must do a lateral chest X-ray, not at all, or impossible to do with an echocardiogram. No. So your cardiac and diaphragm borders are preserved, it's just enlarged. Right. When evaluating an abdominal X-ray, that you cannot identify the psoas tract. The findings indicate nothing, this is normal. Patient is constipated, there's something pathological occurring, so further evaluation is indicated. And you suspect that your patient has a large bowel obstruction, you order an abdominal series. What findings will indicate that the patient has a large bowel obstruction? You have a scarred air fluid level throughout the abdomen, dilated bowel on the periphery with ostral markings. Yes. You're evaluating a lateral cervical spine X-ray for a possible cervical fracture. What would you look for after you verified that you can see all 7 cervical vertebral bodies that would indicate potential fracture? So you see all 7 cervical vertebral bodies, you look at everything, everything looks normal to you, but you're suspecting a fracture.
Soft tissue swelling.
Soft tissue swelling. Remember what I told you, you don't see it, look at the soft tissue swelling, or look at air in the soft tissue. That is indication of a fracture. Now, again, For the hand, for example, basically look at the linings. All the metacarpal bones to see they're completely aligned and fused. If you have any type of misalignment in the periphery, and you don't see it much, but you have a misalignment here, you have like a stylet coming out. For the elbow, sometimes you don't see the fracture itself, even if you do an AP, PA, or lateral view, but one of the indications of fracture in the elbow is what's called saline sign. Let me open an elbow for you, because it's so highlighted so you don't see it. This column of air should not exist. So it's air in the fat area. Do you see that lining?
Yeah.
Dark? That's called cell sign. Okay? So that is an indication of the fracture. Saline sign or cell sign is right here.
It's an indication of what?
Of elbow fracture. I don't know if you're able to see the column of air here. And of course, the patient's gonna come in with pain at the level of the elbow and a history of any traumatic injury. Again, misalignment of the foot. Now, this is mostly for pediatric patients, the same as Harris disease, but we can also have it as adults if we have any type of traumatic injury, like if we're overusing the knees, for example, for those patients that install floors that they're kneeling down all the time, or if, for example, you exercise a lot and you run constantly, or you like to do the type of sport that you have to climb constantly, that can also injure your knee. So basically, Osgood-Schlatter disease is no more than an inflammation and also a protuberance of the ligament that attaches the femur with the tibia. Okay? So basically, it's an inflammatory process at the level of the ligament that attaches to the tibial tuberosity. So basically, it's due to overuse of that ligament, and as I said, it is kneeling down all the time. You have to ask the patient what do they do for hobbies or living, as work. And if their work-related conditions are like kneeling down all the time, or they're highly involved in sport, most of the time they do have a condition which is called Osgood-Schlatter disease. What do you do for that? Physical therapy and ultrasonography, because ultrasonography is not only for diagnosis but also for therapeutic purposes. And if it's not, of course, anti-inflammatories, and if it's not resolved, then you have to do surgery. But again, there's no fracture whatsoever. This is no more an inflammatory condition at the level of the ligament that attaches to the tibial tuberosity due to overuse. Okay? So you do all the views that you can imagine, and there's no fracture. You can even do a scan of your knee, and there's no fracture. Okay? It's just inflammatory process. Now the shoulder, the normal anatomy of the shoulder, if you recall, you have the scapula back here, right? In the scapula, you have a fossa, which is called glenoid fossa, okay? That the glenoid fossa not only is attached to the clavicle, but it's attached to the head of the humerus, okay? So when you do an AP or PA view of the chest, of course concentrating on the shoulder, what you see is, again, imaginary of course, this is the head of the humerus, and this is the glenoid fossa of the scapula. So you have to see a sign that we call the Olympic sign, because if you continue doing the rings, it's the Olympic sign, or it's no more than an overriding of those two imaginary circles, which is the head of the humerus and the glenoid fossa. That means that the head of the humerus is well attached to the glenoid fossa where it's supposed to be. All right? So far so good? So basically what you're looking at is a misalignment. Okay? So if the head of the humerus is displaced, and even though you do have some superposition of those circles, if the circles are like twisted, there is a dislocation of the shoulder. Do you understand? They have to be like an Olympic sign, next to each other. If they're like either like this, or like that touching, or here, not good, okay? So that means dislocation of the shoulder. And what do you do for that? You have to relocate. You have to relocate, or surgery. If the ligaments have torn, you have to do surgery. There's no other way. See? You have two types. You have anterior, which is the most common, almost 90%, and you also have posterior. But if you see, even though they still have a position, they're not next to each other. They're like this or touching. Okay, this is barely pediatric population. Okay? So if you want, I can explain it, but there's no need. What is Salter-Harris classification? Basically, if you remember, in any long bone, you have what's called epiphysis and diaphysis, right? And the cortex, right? Metaphysis, which is the center, epiphysis and diaphysis, right? So this is no more than a damage produced by a fracture of the growth plate. Okay, remember that even though it could be present in an adult, rarely, because this is the damage of the growth plate, and we already have solidified, and we, even though we still have epiphysis, metaphysis, and diaphysis, it's already solidified, okay? And there's no more growth anymore. So there is 5 types, and it's called Salter-Harris classification, because first of all, who discovered it, the name of the guy was Salter-Harris, but also he named it according to his last name, right? So, for example, number 1, type 1 fracture, he called it either same or slip. Basically, what happens is that in 1, you have the epiphysis, the growth plate and the epiphysis, and basically it's a transverse fracture across it, okay? So, same, across, slit, right? So, as you can see, it's highlighted the S for Salter, right? Then, type 2, what happens is that starts from above, as you can see, from the top, and it goes down to the diaphysis. So it could be here, it could be down here. So basically it starts from the epiphysis and goes down to the diaphysis. So that's why it's called above, okay? 3 takes the entire growth plate and crosses, even though it's not showing here, crosses epiphysis and it goes down to the diaphysis. Type 4 is everything, as you can see. Growth plate, epiphysis, and even can go across. So 3 and 4 are highly similar. And 5, he also called, which I have it listed here, is called ruined. From the R of the Harris, it says here crushed or rammed, but he also named it ruined. You're like, you're ruined, you're screwed, okay? Because what you have is basically a compression fracture, like it's all crushed, okay? So the crushed fracture. So you can imagine that the first 2 types are the ones that have a better prognosis. For the child to continue growing, right? Fracture to be solidified, repaired, and the child to continue growing. Otherwise, it's going to affect growth and development. All right? So here is the explanation of 1 in an actual x-ray. So basically, the fracture is all across. In 2, if you remember, is basically from above, okay? But here is there's also another fracture at the level of the head of the tibia. 3, as you can see, is lower, so it's come from the diaphysis all the way down. And 4 is everything, so all the way. And 5 will be crushed. So basically you don't see much, but all is like meshed in, okay? Any question? That's it. After that is basically like more questions that you can practice. Okay, let's go through the questions. Well, not the question spaces, I guess. So, but again, I mean, the X-rays are so bad that I don't even know much. So, what do you think about this X-ray?
You cannot see the
That's the problem. I don't see much.
That's
It's
lower.
everything is dark.
yeah.
I mean, unless
Contraindicate.
this is left, this is right. What I see wrong is the gastric bubble on the right side. Maybe the patient has dextrocardia, most likely, or it's completely reversed, or it's labeled wrong. That's, but I can't tell you more because the X-ray is not good. Huh? So again, I mean, this should be right. So if it's marked wrong, most likely what happens is that you took a picture PA and it was labeled AP and then it was placed left and right. Do you understand what I'm saying? Or if it's labeled correctly, the patient has dextrocardia with situs inversa, meaning that all the organs are switched to the other side. That's the only thing that I can think of because the X-ray is not good. So the gastric bubble should be on the left, the heart should be on the left. So why this is marked left and not right? Same here. So why this is marked left if the gastric bubble on the heart is on the right? So 1 is marked wrong. 2, you have dextrocardia with situs inversus. That's the only thing that I can think from that slide. So what's wrong there? No, that's a no.
Just
I
the
mean, if you,
fingers.
if you do a lot.
Maybe an arthritis, that's deformed.
6 fingers.
Do you have any type of fracture?
Yeah, the pinky. Well, look at the between the index and the finger.
The corner.
Like
The rest are like this due to, I guess,
No, there's a little.
you have soft tissue swelling here and here too.
Arthritis. Arthritis.
I think it's looking over here.
So again, yes, as I said, soft tissue swelling. What about here? And also the space is slightly compromised.
Yeah, the first part of partial on that
And also
pinky.
here, look. Look at this line here. So the fractures are maybe level. The same, this is obvious. You see this? It's a fracture here. This is obvious too.
No.
Exactly. You can't see that, then. This is also evident, but that's what you're gonna get, unfortunately. I mean, fortunately for you, but unfortunately because you have no enough practice. This is obvious, so this is what you're gonna get. And also, look at the alignment of the cervical spine. What did we talk about? Imaginary anterior line is, if you trace an imaginary anterior line, is that unaligned? Cervical spine is actually coming like this. So that misalignment means fracture. Cervical spine dislocation. The same as here. First of all, the space between the occiput and the atlas is very narrow. Second of all, look at the space between the atlas and the rest of the cervical spine. They're torn. What is this? If the patient, if if I tell you that the patient has high fever and has
Right,
AP,
So the one, I was going to be.
and the rest are only pictures. Look at that hand. And look at the X-ray of that hand. It's all very machine. What do you see here? Do you see that the actual femur? Well, actually, this is
Yes.
oh, this is the
My God.
Do you see that the actual femur is crushed into the tibia? Look at the head of the femur.
Yeah.
Do you see those spikes coming up? That's that the head is crushed. Fracture of the finger. Yeah, but no, it's actually the finger. Because the rest is okay. In an X-ray, it was okay. It's just the finger that's fractured. Here as well. Oh, this is after surgery, and this is a nail. So what do you mean when they say you mean?
Or you have that, like, on that one on the next one, you have an obstruction. No, that's not, the one, the other one is in the center, so.
Look at the spine guys.
Spine is fractured.
It's all crushed.
Mhm.
What about that?
Small bowel obstruction.
Small bowel obstruction. How about here?
Peripherally, so that'll be.
Peripherally large. So what do you see here? Well, I don't see the fracture, but do you see that air in here? So there's soft tissue swelling here and here. About there, of course it's obvious, even though the arrow is there. Look at that. Okay? And also the patella is displaced. So the patella is completely fragmented. And, well, that's not the best view though, but anyways, you have the heart that is completely opaque. And I have no idea what the heck is this. But again, it's not the best. But what about this?
It looks like snow. Why is there snow on an X-ray?
That's air. Those are bullets. Those are bullets. But you also see
Where?
a TB, which is called miliary TB. Very similar pattern. But those are bullets.
A shotgun.
Now again, it could be pleurisy from miliary TB, but it's not subcutaneous emphysema. It could also be no, because it could be old. It could be old. Yeah, if you shoot with what is it called? No. Shotgun. It's like scratch pellets. It's not like millions of bullets. It's just one shot. That's scratch bullets within you. And a bottle inside the rectum. And again, I don't know what is this. It's not the best image either. And that's it. He fell on it. So again, he fell on it. I was just trying to open the bottle. So bring your notes and whatever you need to for the exam next Tuesday.